Hello, Doctor,
Everybody
can
here?
we start now?
Yeah, you can start now.
Okay. Okay. Hello and good morning. I bid to our supervisor, Dr. Chan, and my fellow friends. Today, my group, Seminar Group 3, will be presenting about tropical infectious disease, which comprises a few topics, which are dengue fever, tuberculosis, malaria, pertussis diphtheria, and also leptospirosis. My name is Muhammad Afiq bin Muhammad Syarin. Today, I'm going to share about dengue fever. So here my outline for dengue fever, starting from the introduction up until vaccine for dengue fever. So what is dengue? So dengue is basically a viral infection which caused by enterophore, virus, which carried by mosquitoes, particularly Aedes aegypti and albopictus. There are 4 serotypes of dengue, which are DEF1, 2, 3, and 4. So when a person being infected, the virus incubates for about 3 to 7 days, and on average up until 2 weeks. Next, let's take a look at the epidemiology of dengue and how this infection affected all over the world. So based on World Health Organization, WHO, the epidemiology of dengue fever showing an increment trend of 1.8 million people from 2010 to 2019. In fact, Malaysia has been stated as one of the most infected countries in South East Asia, with 131,000 people being infected. The infection basically occurs in subtropical and tropical region. That's why we can find this dengue fever or dengue infection in the Southeast countries such as Malaysia, Indonesia, Philippines, and Vietnam. And we can also found in tropical regions such as in Brazil. Okay, next. When we zoom in the case in Malaysia, the distribution is more in the urban areas, which is 70 to 80% from the total cases in Malaysia. However, there is a limited data in children, as this infection commonly affecting the adults. Okay, next. There are few risk factors that contribute to this increment of dengue cases all around the world, which are climate changes, urbanization, massive infrastructure development. So all these factors are said to be associated with rapid breeding of mosquitoes due to compact or what we say the place is too crowded. Okay. Now I will explain about the pathophysiology of dengue fever. So when a person being infected, the virus will go into the bloodstream, causing the viremia, thus activate immune response. Some of the virus will spill over in the dermis and epidermis, causing immature Langerhans cells and keratinocytes to be infected. So this infected cell will then migrate to lymph nodes, where monocytes and macrophages can be found, which later can produce antibody, IgM and IgG. This later can activate complement system C3A and C5A, causing acute increase in vascular permeability. Later on, it will lead to leakage of plasma into extravascular compartment and causing hemoconcentration. And the most severe part is can develop hypovolemic shock. So the body will try to compensate this problem by reflex tachycardia and generalized vasoconstriction, resulting to a lot of physical signs that we can find in the physical examination, such as coolness, pallor, delay, CRP, reduced uric output, and restlessness. Okay, next. Okay, dengue viral illness can be divided into two, which are dengue with no warning sign or with warning sign, and severe dengue. Severe dengue can be evident with severe shock, respiratory distress, severe hemorrhage and organ failure. Okay. When a person comes to us with a history of fever or any two of the following symptoms such as nausea and vomiting, rash, body ache and pain, positive tourniquet test and leukopenia, we might suspect this patient might have dengue. So we need to ask further question. We need to have thorough history taking lah. So we need to ask about the living area and also traveling history to the dengue endemic areas. So don't forget to ask history about the warning sign, which I can simplify into easiest mnemonic, which is crample, started with C, clinical fluid accumulation, R, restlessness, A, abdominal pain, M, mucosal bleed, P, persistent vomiting, L, liver enlargement more than 2 cm, E, elevated hematocrit, and D, decreased platelet. Okay. Next, for the severe dengue, there are several criteria have to be met. First, there is severe plasma leakage, which can lead to shock and also fluid accumulation with respiratory distress. Second, severe bleeding, which need further evaluation by pediatrician. And third is severe organ involvement, such as in liver, CNS, and heart. Okay, next, we go to the different phases of dengue. So we have febrile phase, critical phase, and recovery phase. So in febrile phase, the patient may present with high-grade fever, accompanied with facial flushing, skin erythema, myalgia, and also headache. So in this phase, in this febrile phase, we expect that in the lab investigation, didn't show much of changes in terms of hematocrit and platelets. However, we can look for progressive decrease in white cell count. In critical phase, there will be a rapid drop of body temperature coincident with increased capillary permeability, as I mentioned in the pathophysiology. So actually, we only worry in this critical phase about the high possibility to progress to shock, which can later cause death if we doesn't tackle or we doesn't treat the patient accordingly. At this phase, we also can expect that there will be thrombocytopenia and hemoconcentration, evidenced by rise in hematocrit. And the last part is recovery phase. So in recovery phase, everything is going back to normal lah. So there will be plasma leakage will be stopped and followed by reabsorption of extravascular fluid. And some patients may have a classical rash of eyes of white in the sea of red in the recovery phase. Next, we go to lab investigation, which I further divided into diagnostic and monitoring severity. So basically, in diagnosing the dengue fever, we can order rapid combo test as early screening, but we need to confirm with dengue antigen and serology test by ELISA, such as NS1 antigen, IgM, and IgG. So as for us, we need to know lah the period of incubation because different tests detectable at different time. For example, NS1 antigen. NS1 antigen can be detected for the first 5 days of illness, and it starts to drop after day 5 of illness. For IgM, it started to rise at day 4 up until day 7 of illness, and IgG a little bit late after day 7 of illness. Same goes to real-time PCR, which can be detected in acute phase, which is before then day 5 of illness. In terms of monitoring severity, we can order food blood count to look for any evidence of progressive decrease in white blood count, platelet reduction, and also hematocrit increment in the critical phase. Okay, next, for liver function test, we can order liver function test to look for any evidence of transaminitis. For renal profile, we can look for urea and creatinine to look any sign of dehydration and also suggestive of acute kidney injury. Others will be coagulation profile, lactate, and blood gases. Okay. In terms of management, I divided into three, which is first, in febrile phase, we can give antipyretic to resolve the fever. We can give analgesic for body ache or muscle pain, but not aspirin because it can worsen thrombocytopenia in the febrile phase. If the patient come with the dehydration or the patient is dehydrated, we can give some fluid replacement. In critical phase, the most important part is fluid resuscitation because patient may have fluid leakage into the extravascular compartment. So if the patient have the compensated shock, so we can resuscitate with normal saline or ringer lactate at 10 to 20 ml per kilo over 1 hour, and we need to monitor frequently because if they show any improvement, we can reduce the fluid subsequently. If the patient can tolerate with oral intake, we can also reduce IV fluid more rapidly. So we need also to recognize hemorrhage because in this especially in critical phase, they tend to have hemorrhage manifestation. And lastly, we need to prevent fluid overload. That's why we need to monitor our patient for about within the period 24 to 48 hours. Lastly is notification. So we need to notify this the dengue cases at the health office within 24 hours to reduce the risk of dengue transmission in the community. Next. So this is how the volume replacement ataupun or fluid resusc in severe dengue and also compensated shock. Next, we go to the last part of my presentation is dengue infection, which is the one the first dengue vaccine found. So it is used in individual aged from 9 to 45 years old with 3 dose series. However, if the patient never be infected by dengue before, so it is not recommended to give this vaccine because it can develop more serious cases. So Health Ministry has decided that the vaccine is not part of National Health Immunization Program, and most of the health facility in this country, in Malaysia, doesn't have this dengue vaccine. I think that's all for my part. Let's we go to the presentation.
Any questions? Let's start now. There's so many. Any questions? No, looks there's 5, right? Better ask in between. If no,
Yes,
then
sir.
we just continue. Any questions not for? Because there's so many, you better ask in between.
Any question from the?
Sarah?
No.
Sarah?
Okay, so now I will be presenting about childhood tuberculosis. Before that, you all can hear my voice, right?
Yes.
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 Good morning to Dr. Chan and to everyone. I am Siti Sarah Sorfina, and today I will be presenting about childhood tuberculosis. Next. Okay, so these are my outlines starting from introduction, epidemiology, risk factors, clinical manifestation, pathophysiology, diagnosis, as well as its management. Next. Okay, so as for introduction, tuberculosis is basically a disease whereby there is presence of symptoms, signs, or radiographic findings that are caused by Mycobacterium complex, and it can be either by Mycobacterium tuberculosis or Mycobacterium bovis. Mycobacterium bovis, usually it will cause abdominal tuberculosis, whereby the patient presented to us with ascites or abdominal pain. And usually, how do they acquire Mycobacterium bovis infection is through consumption of infected materials. The clinical manifestations may be manifested as pulmonary, extrapulmonary, or both. And among the forms of tuberculosis that we have is primary tuberculosis, primary progressive tuberculosis, reactivation, as well as latent TB. Next. Okay, so the commonest etiology of tuberculosis in Malaysia is by Mycobacterium tuberculosis, whereby it is pleomorphic organism, weakly gram-positive curve-rod. They are acid-fast, whereby they have the capacity to form stable mycolate complex, and they grow slowly if we culture them on solid synthetic media, whereby it will take up to 6 weeks. And for drug susceptibility testing, it will take additional 4 weeks, and their growth can be detected from 1 to 3 weeks if we use selective liquid media that has radio-labeled nutrients. Next. Okay, for primary TB, the diagnosis of tuberculosis in children is very difficult because usually most of the children will present it to us asymptomatically. That means they do not have the signs and also symptoms. For primary TB, they are asymptomatic in children. However, when we tested them with tuberculin skin test, it is positive. And when we do chest x-ray towards them, there is mild abnormalities on the chest x-ray, such as there is presence of hilar lymphadenopathy or also Gone complex. And this hilar lymphadenopathy may obstruct the bronchi or the trachea. And the common manifestation in children presented with primary TB is that they have presence of lymphadenopathy or extrathoracic lymphadenitis, whereby it mainly affect at the cervical, supraclavicular, as well as the submandibular area. Okay, next. Another form of tuberculosis is progressive primary disease. It is a condition whereby primary pneumonia develops shortly after primary infection, and it may progress to disseminated miliary disease or CNS infection in the first year of childhood life. And then another form is there is also reactivation pulmonary TB, whereby it is common in adolescent and typical presentation in adult, where it confined mostly at the apical segment of the upper lobe or superior segment of the lower lobe. However, in this form of tuberculosis, there is little or no lymphadenopathy because the hypersensitivity reaction has sustained in this phase. And there is also no extrathoracic infection in this form. However, in patients presented with advanced disease of reactivation pulmonary TB, if we do chest x-ray, we can see that there is presence of cavitation. Next. And then there is also another form, which is latent TB. Latent TB is also the asymptomatic stage, but when we do tuberculin skin test, it is positive. However, when we do chest radiograph, it may indicate normal or there is presence of calcification that indicate there is heel infection. Next. Okay, so for the epidemiology of tuberculosis in worldwide, estimated 1 million children has become ill according to WHO in 2017, whereby more than 200,000 of children had died. However, tuberculosis disease, majority of the patients are between 21 to 60 years of age. And for those who are lesser than 14 years of age is only about 2.7%. However, the incidence is getting higher due to immunocompromised patients such as HIV and also diabetes mellitus, infected foreign workers, or drug resistant. And most children, usually they acquire this disease from an infectious adult. Rarely children are able to infect other children this disease. This is because children, when they cough, usually the cough is lacking. So the tussive forces to project the tubercle bacilli to become droplet nuclei in the environment is very less. So that's why that explains why most children how do they get tuberculosis is because they have a recent close contact with an adult that has active tuberculosis. And the transmission is through respiratory droplets, through droplet nuclei. Next. Okay, among the risk factors for them to have tuberculosis is when they have close TB contact with an adult that has active tuberculosis, or if they are malnourished, immunocompromised patient, or when they live in overcrowded areas, because these areas are more prone, it is much easier for them to get the infection, or if they are less than 5 years old of age, because their immunity is lesser than the adults. Next. Okay, for the clinical features like what I have mentioned earlier, it may be manifested as pulmonary, extrapulmonary, or both. And among the commonest symptoms, sign and symptoms for those who have pulmonary tuberculosis is that they can present it to us with fever, cough, weight loss, night sweat, and also respiratory distress. And for pulmonary tuberculosis, usually they will affect the lung area. So the patient can present with chest pain, hemoptysis, presence of productive cough, and also prolonged cough. Next. For extrapulmonary, it depends on where the tubercle bacilli has been disseminated to. This tubercle bacilli can be disseminated either through lymphatics or through blood system. If it disseminate to the central nervous system, the patients may present it to us with a headache or increase in drowsiness, so leading to maybe we can say that they have tuberculous meningitis. Or if this tubercle bacilli has disseminated to the lymphatics, it can cause lymphadenopathy at that area. For pleura, it can cause tuberculosis pleurisy, or if it has been disseminated through the whole body, it can cause miliary tuberculosis, whereby the patients can present it to us with prolonged fever. And if this tubercle bacilli disseminated to bones and joints of the spine, it can cause swelling at that area, and also it can cause loss of nerve function. If this tubercle bacilli disseminated to genitourinary area, which is very rare in children, it can cause urogenital tuberculosis, whereby the patients can present it to us with sterile pyuria, dysuria, with all the urinary symptoms. Next. Okay, so now I will be explaining about the pathophysiology of how can these children actually acquire tuberculosis infection, starting from primary infection through the inhalation of droplet nuclei that remain infectious in the environment when an infectious person cough, laugh, or sneeze. Okay, so when they inhale this, droplet nuclei, the bacteria will be transmitted to the alveoli. There, it will deposit and also multiply in number. Small amount of this tubercle bacilli will then be transported to other parts of the body, either through lymphatics or through the blood. And at the same time, the one that is there in the alveoli will release exudate, causing pneumonia. And then at the same time, our body will start to, our body immune system will start to release the white cells so that they are able to phagocytose the bacteria. So these white cells will then form a protective mass around the tubercle bacilli, forming granuloma, whereby here they will keep the tubercle bacilli contained inside the granuloma. So this is a phase whereby the patients have latent tuberculosis and it is non-infectious. Okay. Granuloma or gone complex. Okay, and then it can also releases cheesy mass, whereby it will calcify and turn into collagenous scar. And from this one, from the part when they have this granuloma, it depends on the person's immune system. If their immune system lowered and they get reinfected, so and when their immune system lower and they get reinfected, the dormant bacteria will start to be activated, multiply in number, and causing the disease to be manifested worsen. The gone tubercle may be ulcerated. Bacteria will then become airborne and spread. Tubercle will then heal, become scar tissue. The lung will then be inflamed. It may spread to hilum and also adjacent lobes, and causing further worsening of the symptoms. Next. Okay, done with the pathophysiology. Next is how can we actually diagnose tuberculosis in children? As what I have mentioned, it is difficult because most of the children will present it to us with asymptomatic. That means they have no clinical signs and also symptoms. But the first one that is very important is that when we ask, do they have any recent contact with a person which is adult with active tuberculosis, because it is one of the strongest evidence of TB in a child who has symptoms, or maybe if they do not have symptoms, when we do chest X-ray, it reveals abnormalities of the chest X-ray that may be suggestive of TB. And then the second way of how can we diagnose tuberculosis is by through signs and symptoms that suggest TB. And usually infants, they have non-specific symptoms such as low-grade fever, cough, weight loss, failure to thrive, and also among the signs are wheezing, reduced breath sound, tachypnea, and also respiratory distress. Another way is by doing a Mantoux test or tuberculin skin test, and they are positive when they have more than 10 millimeter in duration at 72 hours. And when we do chest X-ray towards them, the radiographic finding suggests abnormalities such as there is enlarged hilar lymph nodes in patient with primary infection, or there is persistent segmental collapse consolidation, pleural effusion, or calcification in the lymph nodes. And the last way on how can we diagnose is through lab test, whereby there is presence of acid-fast bacilli on the smear. Next. Okay, for the diagnosis workup, it is basically tailored to organ system. For example, if a patient presented to us and saying that he has a recent close contact with a TB patient, so we might be thinking that this is a TB infection. However, the patient presented to us with extra pulmonary symptoms, such as he presented with a headache or increase in drowsiness. So we might be thinking that the tubercle bacilli has been disseminated to the central nervous system. So which why we will do investigation, we will do procedure to collect samples so that we can say that this is a form of extrapulmonary manifestation that has been manifested to the central nervous system area. So if the patient only presented with pulmonary TB, we can do chest radiograph or early morning gastric aspirate in children who are not able to produce their own sputum for more than 12 years of age, pleural fluid, or biopsy. For CNS TB, we can take cerebrospinal fluid for FEME, AFB smear, and also do CT head and contrast. For those presented with ascites or abdominal pain, so we can say that this perhaps a presentation of abdominal TB. So we can do CT abdomen with contrast and also biopsy of mass if there is any. For those who presented with skeletal problems, so we can say that this is TB osteomyelitis. So we can do CT or MRI of the affected limb and also biopsy of the affected site. And if it is only disseminated throughout the whole body, whereby the patient presented to us with prolonged fever and prolonged cough, so we can say that maybe this is a form of miliary TB. So the diagnosis workup is that we have to do the same as what we do in patients with pulmonary tuberculosis only, whereby we do the chest radiograph, gastric aspirate, and at the same time we have to do early morning urine because we are afraid that it might go to the genitourinary area, as well as we can do cerebrospinal fluid if it go to the spinal area. Okay, next. Okay, so like what I've mentioned, one of the way for us to diagnose tuberculosis in children is through doing them tuberculin skin test, whereby it is an intradermal injection of tuberculin material. And it is considered positive when they are more than 10 millimeter in duration at 72 hours. And if it is true positive, it indicates latent infection. And we can classify these patients based on the induration that is there, which is more than 5 millimeter, more than 10, and also more than 15. For those patients, children who are under 4 years of age with no known risk factor for TB, it is more than 15 millimeter in duration. more than 4 years old, bukan less. And then those who are more than 10 millimeter, those who are categorized under this category is those who have those who recently arrived from high prevalence country, or IV drug users, or children who are lesser than 4 years old. And for those who are listed under 5 millimeter in duration, is when they have is when they are HIV positive, recent contact with active TB patient, or when they have fibrotic changes on the chest X-ray. Next. Okay, like what I've mentioned is that we have to do AFB smear. And how can we actually obtain this smear? For smear microscopy is through 3 ways. The first one is through expectoration. Sputum should always can be obtained in adults and also older children who are more than 10 years or more than 12 years of age, who are able to expectorate their own sputum. However, in children who are lesser than 5 years, they are difficult to obtain sputum, and most of them are smear negative. So how can we do this is, next, we can do gastric aspiration. It is performed in young children who are unable to expectorate their own symptoms because they swallow the mucus. So we will take the swallowed mucus in the stomach 3 times every morning, whereby the nasogastric tube is placed transesophageally. Okay, next. Another way is through sputum induction. It is safe and effective in all children of all ages, and the bacterial yields are as good or better than gastric aspirate because it has a wider bacterial field. And what makes it different from gastric aspiration is that it has a nebulizer, whereby there is presence of 20 ml of hypertonic saline solution. So we induce sputum to be expectorated from the patient. Next. Okay, so how can we manage in children with tuberculosis is through short course therapy, which is indicated for children who have pulmonary TB or less severe form of extrapulmonary TB. And it consists of 2 phases, which are intensive phase and maintenance phase. For the intensive phase, it is 2 months, whereby the patients require daily intake of isoniazid, rifampicin, and pyrazinamide, and ethambutol is only given when the drug is resistant or when there is extensive disease of the tuberculosis. And maintenance phase must be continued for another 4 months, whereby we will give them isoniazid and also rifampicin. And for those who have latent tuberculosis infection, we will also give them isoniazid and rifampicin. And all of this medication should be taken in front of the authorized medical personnel. For those who have tuberculous meningitis, miliary, and osteoarticular tuberculosis, the indicated time therapy for them is 12 months of duration. Next. Okay, we can also give them corticosteroid for those who have TB meningitis or children with pleural and pericardial effusion, severe miliary disease, and endocardial disease. And they are given with appropriate anti-tuberculous therapy like what I have mentioned earlier, isoniazid, rifampicin, ethambutol. And the dosage is, we will give them prednisolone 1 to 2 milligram per kilogram per day for first 3 to 4 weeks, and then will be tapered over. Next. However, we should monitor the drug toxicity and we should request for baseline and routine monitoring of serum transaminases, especially in patients who have severe TB disease, clinical symptoms of hepatotoxicity, underlying hepatic disease, use of other hepatotoxic drugs such as anticonvulsant, and also those who have HIV infection. And this routine testing of serum transaminases in healthy children are not necessary. If we give the children ethambutol, for example, they have severe TB disease, or when the drug is or when there is drug resistant, and so we give them ethambutol. So we should monitor for their visual acuity and also color discrimination, because one of its side effects is color blindness. Next. Okay, so these are the drug mentioned in tuberculosis chemotherapy, comprises of isoniazid, rifampicin, pyrazinamide, and ethambutol, whereby they have to be taken for 6 months duration. And isoniazid and rifampicin are taken for those who have latent TB infection. Next. Okay, so this is the algorithm on what to do when a child is in contact with a TB patient. So we will classify the patient whether they have a significant contact or no significant contact. And if they do, we will further divide them based on their age, which is less 5 years of age, or if they are immunocompromised and also more than 5 years of age. And we will classify them accordingly based on whether they have the symptoms or if they do not have the symptoms. When we do radiographic examination, we see that the chest X-ray is abnormal, or when we do tuberculin skin test, it is positive more than 10 millimeter in duration. Okay, that's all from me. Is there any question? Okay, if there is no question, thank you everyone.
Okay, so next I'm going to present about malaria. But before I start, can everyone hear me?
Yes.
Yes.
Okay, for malaria, my name is Sharafina Shaharin. Okay, first, this is my outline for the presentation. As for the introduction, malaria is actually a life-threatening disease caused by parasites transmitted to people through the bites of infected female Anopheles mosquito. And once it enters the bloodstream, it will infect and destroy mainly liver cells and red blood cells. And children under 5 years old are more susceptible to this infection because of their underdeveloped immune system. And malaria is actually a preventable and curable disease. As for the etiology, it is caused by the Plasmodium species, and it is an obligate intracellular protozoa. There are hundreds of species of Plasmodium, but only 5 cause disease in humans, namely malariae, falciparum, vivax, ovale, and knowlesi. And the vectors are female mosquito like Anopheles maculatus and campestris. As for the epidemiology, in 2018, there was an estimated of 228 million cases of malaria that occurred worldwide. And there were an estimated of 405,000 deaths from malaria. And children aged under 5 years are the most vulnerable group affected by it, and even accounted for 67% of all the deaths worldwide. And tropical and subtropical region are hit the hardest, and together, the most affected region forms the malaria belt, which is a broad band around the equator that includes much of the Latin America, Sub-Saharan Africa, Southeast Asia, and also South Asia. As for the risk factors, first are infants and children under 5 years old, pregnant women, HIV and AIDS due to their immunocompromised status, non-immune migrants, and also travelers to endemic area of malaria. Next, I'll explain about the pathogenesis. So first, the mosquitoes will get attracted to human via the carbon dioxide that we breathe out, and also the bodily smells like smelly feet. And when the proboscis of the mosquito pierces the skin, it will release the sporozoites into the bloodstream. And this sporozoite will reach the liver within minutes and will start their asexual reproduction to multiply. And in the liver also, this sporozoite will mature to become merozoites. And Plasmodium vivax and ovale can enter dormant phase in which they will become inactive for a long period of time before becoming active at a later stage of life. And this merozoite will eventually spill into the blood and will bind to surface receptors on blood and invades red blood cell. For falciparum and ovale, they are especially dangerous because it can invade red blood cell of all ages, including the immature ones like reticulocytes. And inside the red blood cell, this merozoite will undergo asexual reproduction to divide more. And red blood cell that contains merozoites are called schizon. So when the numbers are overwhelming, this schizon can rupture and spill into the blood. When it is spilled into the blood, this merozoite can infect other red blood cells. And some of it can undergo gametogony where they become gametocytes. And this gametocyte will be sucked by mosquitoes, and inside the mosquito, they will undergo sexual reproduction to produce more sporozoites. And then the cycle will repeat all over again. For most Plasmodium infected cells are actually screened and destroyed by the spleen. But for Plasmodium falciparum, they can generate a sticky protein that coats the surface of the infected red blood cell, as you can see the dots here, and it will give a knob-like appearance on the surface of the red blood cell. and this protein will cause the red blood cell to clump together. And this clumped red blood cell can get stuck at small blood vessels, a process called cytoadherence. And so this will block the infected cell from entering the spleen to be filtered out, as well as blocking the blood flow to vital organs. When the blood flow is blocked, ischemic damage can occur, which can eventually lead to organ failure. So this is a summarized version of the pathogenesis I've explained earlier. So next, I'll be explaining about the paroxysm. First is the cold stage, where the patient will feel intense cold and vigorous shivering, and this will usually last about 15 to 60 minutes. Second one is the hot stage, where there is an intense heat, dry burning skin, throbbing headache, and this stage lasts for about 2 to 6 hours. The last stage is the sweating stage, where there will be profuse sweating and the patient will feel exhausted and weak. The temperature will also decline and the blood pressure may also drop, leading to orthostatic hypotension. And this stage lasts for about 2 to 4 hours. So these are the fever patterns in malaria: quartan fever, tertian fever, fever that happens every day, and also malignant tertian fever. So for the clinical features of malaria, it is actually non-specific, but through the clinical features, we can classify if the malaria is uncomplicated or complicated malaria. For uncomplicated malaria, it is symptomatic malaria without signs of severity or evidence of vital organ dysfunction. And as for complicated malaria, it is these are the clinical features and laboratory evidence. For the features, there will be impaired consciousness, prostration. Prostration means the inability to sit upright. And for children that are not able to sit yet, prostration is defined as the inability to breastfeed. And then next, failure to feed, multiple convulsion, deep breathing and respiratory distress, circulatory collapse and shock, clinical jaundice, hemoglobinuria, abnormal spontaneous bleeding, and also pulmonary edema. And then the evidence are shown below. So next, I'll be explaining about the complication. First is anemia. Usually in malaria, the anemia is normocytic anemia, and anemia is a major problem in children and may also lead to high output cardiac failure and sudden death. Next is toxicity cytokines, because when the red blood cell bursts, it will release cytokines and inflammatory mediators. So when there is persistent bursting of red blood cells, there will be progressive worsening of the signs and symptoms. Next is tropical splenomegaly syndrome, and this is associated with anemia and also thrombocytopenia. When a patient has splenomegaly, they can have right upper quadrant pain and also risk of rupture. Next is cerebral malaria, and in this, extreme agitation is a poor prognostic sign, and untreated cerebral malaria is fatal, and cerebral malaria has a 15% mortality in children. Renal failure is not as common in adults, so it is quite rare in children, but it is due to microvascular obstruction that will cause compensatory renal cortical vasoconstriction and resultant hypoperfusion and also acute tubular necrosis. Next is acute pulmonary edema, which is a form of acute respiratory distress syndrome. It is due to the sudden increase in pulmonary capillary permeability, and also hyperventilation is a poor prognostic sign. And then for hypoglycemia, it is hypothesized to be because of the increased metabolic demand of the febrile illness and also the demand of the parasite, which use glucose as their energy. And also because of the failure of hepatic gluconeogenesis and glycogenolysis because of the parasite invasion. And lastly is coagulopathy, which is theorized to be because of the reduced platelet survival from peripheral destruction. So next, for the investigation, first is to do full blood count to check for any anemia, to check the white cell count, and to check for neutrophilia and also thrombocytopenia. And then to do a blood film for malaria parasite. This is to be done immediately, and if the initial sample is negative, we should repeat another 2 samples or more if the symptom persists. And in blood film, we do 2 kinds of blood film, the thick film and also the thin film. For the thick film, we detect the presence of malaria parasite, as you can see here, because in thick film, we can have a broader picture of the blood. So we can see there is a parasite inside the blood. As for thin film, it is for identification of what type of Plasmodium species is infecting the blood. As you can see here, because a thin film is a single layer of blood, so we can see the blood more specifically. So this is an example of falciparum and on. Next is to do we can do a rapid diagnostic test which can detect circulating parasite antigen, and then polymerase chain reaction for confirmation and species detection. The indication to do PCR is when there are clinical symptoms but no malaria parasite seen in the blood film, and also in cases having microscopic appearance of malaria. And then can do the CRP level, which is expected to be raised. Liver profile, bilirubin is often raised due to hemolysis. Renal function test to check for electrolyte imbalance, especially sodium, because salt depletion through prolonged sweating can cause decreased sodium levels. And then also to check for parameters suggestive of hemolysis like haptoglobin, lactate dehydrogenase, and reticulocyte count. For blood glucose, low blood glucose is seen in severe case of malaria, and chest X-ray is not routinely done, but it may be helpful if the patient presents with respiratory symptoms to rule out other.
Did something just happen? Did something just happen?
Doctor, the presenter has a problem.
Her Wi-Fi cut off, is it? No, I'll wait for a while.
Doctor, the presenter's laptop just shut down. So she's trying to restart it.
Okay, we'll just wait for a while.
Hello, can everyone hear me?
Yes.
Yes.
I'm sorry, I forgot to plug in my charger. And
Okay. Okay.
okay, can everyone see the slide?
Yes.
Okay, for the team film, no. Okay, next I will go to management. For the management, we have to know first what type of plasmodium is causing the infection, and is it uncomplicated or complicated malaria, and is the parasite resistant? For example, like if the infection takes place in a part of the world where it is known to have resistance to certain malaria. And also the main treatment is to give anti-malarial drugs because it is more toxic than antibacterials. And the recommended one is ACT, artemisinin combination therapy. We give combination therapy because we want to prevent drug resistance. Because if we give only a single drug, the parasite can figure out how to overcome the mechanism of the drug and cause resistance. So this table is a very, very, very generalized management of malaria. I've classified it into uncomplicated and complicated. So for falciparum, the first line treatment is to give artemether or lumefantrine or Riamet, and the alternative is to give artesunate and mefloquine or ASM2 for short form. And the dosage for it is actually according to body weight So you can refer the PITS protocol for the exact dosage. And second line treatment is to give alternative ACT or artesunate and clindamycin or quinine and clindamycin or primaquine to all patients on day 1. For other type of plasmodium, the preferred one is to give Riamet or ASMQ and primaquine for 14 days. And the alternative is to give chloroquine for 3 days and primaquine for 14 days. As for the complicated malaria, the treatment is the same for all species of plasmodium. So the first line is to give intravenous artesunate. Second line is to give intravenous quinine or doxycycline and clindamycin. So I think that is all for my presentation. Is there any question? If there is no question, we can proceed to the next presenter.
Assalamualaikum warahmatullahi wabarakatuh. I'm Shafatin. I will continue the presentation for the next infectious disease, which is pertussis, or commonly known as whooping cough. So next. This is the outline of the presentation. Next. As an introduction, pertussis is an acute tracheobronchitis that began with mild URTI symptoms, followed by a severe paroxysmal cough. It is highly contagious. Children below 5 years old are most commonly affected, constituting 90%, in which from this 90%, 70% of them are not vaccinated. Next, the most common causative organism is the bacteria Bordetella pertussis. It is an encapsulated gram-negative coccobacillus. It infects only human and can be transmitted person to person by coughing or sneezing. And then for the pathophysiology, when people near the child cough, the pathogen will be transmitted via airborne droplets, and then the pathogen will then enter the child respiratory tract and attach its villi to the cilia of the epithelial cell, decreasing the ciliar activity followed by death of ciliated epithelial cell. So the pertussis toxin stimulate adenylate cyclase. Then there will be a rise in cycle AMP dependent protein kinase activity, causing a failure of lymphocytes to enter the lymphoid tissue, resulting in striking lymphocytosis in the blood. So next, typically the incubation period of pertussis ranges between 7 to 14 days. Symptoms then usually persist for 10 to 12 days. The most contagious period is the first 2 weeks of cough. So for very young infant, around less than 3 months, cough and catarrh symptoms are less marked, but they can have a recurrent attack of apnea and cyanosis. This disease is divided into catarrhal, paroxysmal, and also convalescent stage. So the catarrhal phase, it is indistinguishable from common URTI. It includes nasal congestion, rhinorrhea, sneezing. So it also variably accompanied by low-grade fever, tearing, and also conjunctival suffusion, conjunctivitis. So pertussis is most infectious when patients are in the catarrhal phase. But pertussis may remain communicable for 3 or more weeks after the onset of cough. So, in the paroxysmal stage, it is occur usually about 3 to 6 weeks, but can be up to 3 months. So in this phase, a patient will present with paroxysms of intense coughing, lasting up to several minutes in each episode. So this is the period when a whooping cough can be seen with 4 main characteristics, which we will go through briefly in the next slide. And then a patient in the convalescent stage will have a chronic cough, which may last for weeks or months. Next. The first characteristic of whooping cough is the repetitive pattern. There will be a series of about 5 to 10 frequency of cough without taking breath in between the cough in a single expiration. So this pattern of cough, repetitive pattern, is needed to dislodge the plaques of necrotic bronchial epithelial tissue and thick mucus. Next is the inspiratory whoop, which refers to the forced inspiration against closed or partially closed epiglottis following the paroxysmal cough. And the third characteristic is vomiting of the ingested food or the thick mucus. And lastly, facial congestion due to copious mucus flowing from nose and mouth. In severe cough, the children can have conjunctival petechiae or conjunctival hemorrhage and also epistaxis. Also remember that infants may not have whoop, but often have apnea following cough spasm. Next. This diagram or timeline is just a summary of the 3 stages of pertussis just now. Next. The diagnosis, it depends on isolation of Bordetella pertussis or detection of its nucleic acids. So we can take nasopharyngeal aspirates for PCR. It is rapid and sensitive, but not really specific. Other than that, serology test is not recommended because it is not useful for diagnosing acute infection, but convalescent phase is confirmatory using serology test. Also, we can do culture from nasopharyngeal aspirate, but the result is highly affected with antibiotic. And next investigation is to do nasal swab or sputum for culture. However, it is unsatisfactory because organism can die on the way to the lab and is slow to culture. So from blood investigation, there will be marked lymphocytosis, rising up to around 15,000 cells per millimeter cubic. Why? Because we already know from the pathophysiology. Next, based on CDC, to diagnose pertussis, the cough should at least last at least 2 weeks with at least one of the following characteristic. And then also isolation of Bordetella pertussis from nasopharyngeal aspirate with, along with a positive PCR. Next, as for the complications, generally the child can be malnourished. In a central nervous system, the complication can manifest as apnea and scapulopathy. From in respiratory system, it could manifest as lobar pneumonia, atelectasis, pneumomediastinum, or emphysema. Other than that, next, these are another complications from due to pertussis. Next, for management, we need to admit the patient if the patient is age is below 6 months old due to the risk of apnea. We should administer oxygen therapy, give mucolytic agent, and also microlide antibiotic. For antibiotic erythromycin, it can eradicate organism if started at the catheter phase, but there will be risk of side effects known as infantile hypertrophic pyloric stenosis. Also, close contact should be given prophylactic antibiotic. Next. There are 2 vaccines that include protection against whooping cough. So the first one is whole cell DTP, in which it contains suspension of Bordetella pertussis that are inactivated. However, it is commonly associated with severe local adverse effects such as erythema, swelling pain, and systemic like seizure and fever. Next is acellular DTAP. It is a purified component of bacterial pertussis, such as inactivated toxin. And this vaccine has a lower frequency adverse effect. Next, so in order to take vaccine, we have to know this precaution. We have to know if there is any severe reaction to previous dose. For example, this reaction, fever within 48 hours of dose. If there's collapse or shock, like state within 2 days. Is there any seizure or persistent inconsolable cry that can last more than 3 hours? So we also need to know about the contraindication for the vaccine, such as anaphylaxis to previous dose and also encephalopathy that developed within 7 days of previous vaccination. Next. So this we can know at what age, at what months that the children will have their dose of vaccine, DTaP vaccine. Next. I will continue the presentation of next infectious disease, which is diphtheria. So, based on pediatric protocol for Malaysian Hospital 4th edition, diphtheria is a clinical syndrome caused by Corynebacterium diphtheria. It can be classified based on site of disease, can be at the nasal, pharyngeal and tonsillar, laryngeal or laryngotrachea, and also cutaneous diphtheria. So this is below is the definition by Nelson, 25th edition. Diphtheria, it is actually a Greek word for leather, referring to the tough pharyngeal membrane that is the clinical hallmark of infection. So despite the worldwide decrease in disease incidence, diphtheria remains endemic in many developing countries with poor immunization rates. So when diphtheria was endemic, it primarily affected children below 15 years old. Factors contributing to the epidemic included large population of under-immunized adults, decreased childhood immunization, population migration, also crowding. Next, Corynebacterium diphtheria is by far the most frequently isolated agent of diphtheria. Next. So, as we already know, the primary mode of spread consists of close contact with infectious material from respiratory secretions, with either it direct or via airborne droplet or from skin lesions. So once the pathogen, the bacteria colonize the mucosal layer and it will remain at the site of infection, then it will release soluble exotoxin, which will be absorbed by adjacent cells. So the toxin will inactivate elongation factor 2, which is required for protein synthesis by the ribosome. So when there is inactivated factor, it will lead to cell death. Next. So within the first few days of respiratory tract infection, which usually in the pharynx, there will be a dense necrotic coagulum of that include organism, epithelial cells, fibrine, leukocyte, and erythrocyte. So it will form, initially it is white, and later it will advance to become a gray-brown, leather-like adherent pseudomembrane, as we can see in the picture. And remember that diphtheria can be classified according to its site. So the most common affected site is, of course, the respiratory tract. So primary focus of infection was the tonsils or pharynx, constituting about 94% of the disease. So next to most common site is the nose and larynx. After an average incubation period of 2 to 4 days, local signs and symptoms of inflammation will develop. In kids, in infants, infection of the anterior nares is more common, where it causes serosanguinous purulent erosive purulent erosive rhinitis with membrane formation. So shallow ulceration of the external nares and upper lip is a characteristic. For tonsillar and pharyngeal diphtheria, sore throat is the universal early symptom. And only half of the patient have fever, and fewer has dysphagia, hoarseness, malaise, or headache. My pharyngeal injection will be followed by unilateral or bilateral tonsillar membrane formation. Other than that, underlying soft tissue edema and enlarged lymph node can cause a bull neck appearance. So, classic cutaneous diphtheria is an indolent, non-progressive infection characterized by superficial ecthyma-like non-healing ulcer with a gray-brown membrane. So extremities are more often affected than trunk or head. So it is typical for the cutaneous diphtheria to cause pain, tenderness, and erythema, and also exudate. But it is unusual for the child to experience local hyperesthesia or hyperesthesia. Diphtheria also can cause infection at other sites, such as ear and also genital tract. Next, for complication in diphtheria infection, the endotoxin produced, it can damage the heart muscle and nervous system, and therefore it will manifest as myocarditis and neuritis. So mortality rate in children complicated by myocarditis is around 50%, while in neuritis, it can be presented as paralysis of soft palate. Usually, when the infection has infected extended to the uvula. Other than that, non-oliguric acute kidney injury can occur, but it is rare. To diagnose, we need to take nose, throat, and any other mucocutaneous lesion swab for culture, whereby a portion of membrane should be removed and submitted for culture along with the exudate. For investigation, from full blood count, we can see moderate leukocytosis. In culture and sensitivity, we need to telluride enriched culture media by using Loeffler or Tyndall. Actually, telluride agar by Loeffler or Tyndall media, whereby the colonies from diphtheria, Corynebacterium diphtheria, will become gray-black in color. Other than that, PCR will demonstrate diphtheritic toxin. Yes?
Everybody keep quiet. Okay, anybody who don't have their microphones muted, please just mute it. Because I can hear background noise. Okay? What's that? Is somebody still in Syafatin kat mana? Kat rumah?
Yes, but the sound is not at house.
Whether that's environmental or whether that's a movie playing in the background, whoever has not muted their mic, please just mute it if you're not talking. Okay? Okay. Syafatin, start balik.
So for toxigenicity test, we can use ELAC test to determine if Corynebacterium diphtheria would produce toxin. Next. So for management, we can treat this patient with diphtheria antitoxin. We give antibiotic therapy, and also we should provide anti-immunization. For the prognosis, the case fatality rate is almost 10% for respiratory tract diphtheria. Next, for prevention, in asymptomatic case contact, all household contacts and people who have had intimate respiratory or habitual physical contact with a patient will be closely monitored for illness for 7 days. They will be the cultures of the nose, throat, and any cutaneous lesions will be taken from them, and they will be administered antimicrobial prophylaxis. Next, in patients who are in asymptomatic carriers, we will administer antimicrobial prophylaxis and give diphtheria toxoid. So okay. So these are differential diagnosis for diphtheria. Is there any question? If there is no, thank you.
Okay, I will continue the presentation. Can you hear me?
Yes.
Okay, I will continue the presentation on the leptospirosis. Next, this is the outline for my presentation. Next. Leptospirosis is a zoonotic disease caused by aerobie and multispirochetes from the genus Leptospira. It causes major mortality and morbidity worldwide, but is more common in the tropic and subtropic country and less common in the temperate country. So the estimated case fatality range for different part of the world range from less than 5% to 30%. So in Malaysia, next. In Malaysia, it causes preventable mortality to the young adults and also to the personnel in high-risk occupation. As you can see, this is the incidence and mortality rate of leptospirosis from 2004 to 2015. The incidence of leptospirosis keep increasing each year. So in Malaysia, the 5 major states with most cases including Kelantan, Perak, Sabah, Sarawak and also Selangor. The leptospirosis is a seasonal disease where its peak is during rainy and monsoon season. Next. So these are the risk factors for leptospirosis. The condition favorable for transmission of leptospirosis including the first one is the reservoir and carrier host. The range of leptospirosis reservoir is wide, including the rodent and non-rodent animals such as the rats, cattle, goats, dogs, and also rabbits. These animals act as carrier and they excrete a large volume of leptospirosis into their urine and are responsible for the contamination of the water and also soil. The second one is the flooding and drainage congestion. Flooding and drainage congestion might be the main source of contamination of water with infected animal urine. The third one is animal-human interface. The potential for infection increase through the exposure from occupation and also recreational activity without proper protection. For example, poor cleanliness can attract animal, including the rodents. And then the fourth one is the human host risk factor, including people with chronic disease and also open wound skin. Okay. Before. Okay. There are some groups that has high risk to be exposed to the leptospirosis, including the workers in the agriculture, sewerage workers, livestock handlers, pet shops workers, military personnel, disaster relief workers, people involved with outdoor or recreational activity, travelers who travel to area with flooding, or travelers who will be swimming, crafting in the contaminated water, and also people with chronic disease and also open skin wounds. Next. These are the mode of transmission of leptospirus. So in human being, leptospirus can enter human through a mucous membrane, primarily the eyes, the nose, and also the mouth. Transdermally through the open wound skin, and also ingestion of contaminated water or food. Next. After the penetration, the leptospirus will circulate in the bloodstream to all body organs, and it can cause endothelial damage of small blood vessel because they secrete the endotoxin, and responsible for secondary ischemic damage to the end organs. Next. For the clinical presentation of leptospirosis, the onset of the leptospirosis is abrupt. It can follow monophasic or biphasic course. The incubation of the leptospirosis is between 2 to 30 days, usually 10 days. The classical biphasic course means that after the incubation period, there will be initial phase and also immune phase. Okay. After this, I will further explain. After the incubation period, it will be followed by the initial phase. The initial phase is also known as the septicemic phase. It lasts about 2 to 7 days, and during this phase, we can isolate the leptospirus from the blood and from the cerebrospinal fluid. And then after the initial phase, there will be a short period of asymptomatic. After this period, there is a immune phase. The immune phase will last for several weeks, and during this immune phase, there is a circulating IgM antibody, disappearance of leptospirus from the blood and from the cerebrospinal fluid. However, the leptospirus can persist in the kidney and also in the urine. And during this phase also, there will be signs and symptoms manifest according to the localization of the leptospirus onto the tissue. According to the guideline from the Health Ministry, the clinical manifestation of leptospirosis in human are highly variable. Therefore, this disease can present in 4 broad clinical categories, ranging from the mild influenza-like illness to severe disease with multiple organ dysfunction. Next. Okay. I will focus in this slide. I will focus on the sign and symptom of Weill syndrome. So in the next. These are the signs and symptoms of mild flu-like illness in leptospirosis. Next. Next. Okay. The symptomatic phase can be anicteric or icteric leptospirosis. As for the anicteric leptospirosis, in the initial phase, as you can see in the left box, for the initial phase, or also known as the septicemic phase, the patient can come with mild flu-like illness, such as fever, myalgia at the lower limb, headache, abdominal pain, vomiting, and also conjunctival suffusion. After the first phase, the patient will have a short period of asymptomatic, and then followed by the second stage, or also known as immune phase. During the immune phase, the patient can come with septic meningitis and also recurrent fever. Only about 50% of the patient come with septic meningitis, although about 80% of the cases have abnormal cerebrospinal fluid profile. Patient can also come with bilateral or unilateral uveitis, but most common is self-limiting. Okay, as for the icteric leptospirosis, it is also known as Wales syndrome. Wales syndrome is a severe form of leptospirosis. The first stage or the immune phase of the Wales syndrome is similar to the initial phase of the anicteric leptospirosis. However, for the second stage, a patient with Wales syndrome can come with jaundice, hemorrhagic manifestation, renal failure, and also myocarditis. Previous slide. Previous. Ni. Okay. In this picture, I will focus on the clinical manifestation of the Wales syndrome. Patient with Wales syndrome can come with pulmonary hemorrhage. This patient can have cough, dyspnea, hemoptysis, and also acute respiratory distress syndrome. The pulmonary hemorrhage can occur secondary to alveolar and also interstitial vascular damage. And also, if there is any liver involvement, the patient can come with right upper quadrant pain, hepatomegaly, direct and indirect hyperbilirubinemia, and also elevated AST, ALT, and also ALP. However, this abnormal liver enzyme will return to normal once the patient is recovered. And also, this abnormality is not associated with hepatocellular necrosis. About 16 to 40% of patients will come with renal failure. And also, more than 50% of the cases, they come with transient thrombocytopenia, which they will have a hemorrhagic manifestation, including epistaxis, GIT bleeding, and also pulmonary hemorrhage. Next. These are the summary of the multi-organ involvement, especially in the Wales syndrome. Next. These are the differential diagnosis of leptospirosis. Actually, the diagnosis only based on clinical manifestation for leptospirosis is very difficult because of the presentation is quite similar to the malaria, dengue, and also hantavirus. So, next. Okay, no presentation of leptospirosis is diagnostic, and clinical suspicion must be confirmed by laboratory tests. As for the probable case, a clinical case with positive ELISA. The ELISA, as we all know, ELISA can detect IgM. Therefore, ELISA is very useful to diagnose a new early infection for the first 3 to 5 days. However, the positive ELISA case must be confirmed by a few other tests, including the microscopic agglutination test, MAT. MAT is considered as a gold standard serodiagnosis. MAT use antigen taken from common or locally endemic leptospira serovirus. Second one is the positive PCR. Next. Positive PCR. So the sample for PCR must be taken within the first 10 days. Why? Because leptospirus only found in the blood or cerebrospinal fluid within the first 10 days or in the initial phase. And then the next one is the positive culture. For the positive culture, the blood sample should be taken for the first 7 days, or cerebrospinal fluid sample for the first 4 to 10 days. And after the 10 days of illness, urine sample should be taken. And the last one is the immunohistochemical staining in postmortem diagnosis. Can you see the slide? Oh no.
No. No, slide ni lah.
Can you see the slide?
Yes.
Oh, okay.
Yes.
Okay. So this is the relationship between the biphasic phase of the disease and also the investigation done at different phase of the disease. You can see, as I mentioned before, we take the blood sample during the first 7 days, because during this time the leptospira persists in the blood and also cerebrospinal fluid, but the urine sample is only taken after the 10 days of illness, because the leptospira is only found in the urine after the 10 days of illness. Okay, these are the additional or routine laboratory studies and imaging in leptospirosis and their expected finding. As for the full blood count, severe anemia can occur in the pulmonary hemorrhage, leukocytosis, and thrombocytopenia. Thrombocytopenia can occur because of the peripheral consumption of the platelet due to widespread of hemorrhage, and thrombocytopenia can occur in the IC. Second one is the serum creatinine, CKMM, is usually elevated in patient who has muscular involvement. For the coagulation time, it might be prolonged if there is liver dysfunction or if there is any DIC. Liver function test, as I have explained before, the abnormal enzyme will return to normal once the patient recover. For the urinalysis, we can see proteinuria, erythrocyte, and also leukocyte presence if the patient has tubular or interstitial damage due to acute kidney injury. Chest X-ray is done in order to evaluate lung disease or to determine the extent of the organ involved. Hepatobiliary system ultrasound can be done in suspected alkalosis cholecystitis, and ECG abnormality or any arrhythmia can be seen in immune phase of West syndrome. Okay. These are the principle of management. Principle of management of leptospirosis in pediatric patient. Okay. In patient who come with mild flu-like illness, we will only treat the symptom or give the symptomatic treatment. For mild cases, we give doxycycline in patient more than 8 years old, ampicillin and also amoxicillin in patient less than 8 years old. And also we encourage the patient to maintain adequate fluid intake to avoid hypovolemia. And for the severe cases, we give IV penicillin G and also third generation cephalosporin. We also monitor and give supportive therapy for multi-organ failure. For example, dialysis in patient with renal failure. And bed rest until adequately resuscitated and treated. Okay, the last one is the prevention and control. The first one is the rodent control, such as we maintain the cleanliness of the recreational area, avoid contaminating water and soils, especially the stagnant water, and also the drain, immunization of the livestock, and also domestic dogs. in order to reduce the leptospirus reservoir. Protective clothing such as boots, goggles, and also gloves must be worn by people who has high risk of occupational exposure. The fifth one is the contact precaution, especially in the hospital setting, in order for potential exposure to infected urine. And the last one is the prophylactic antibiotic given for travelers who will travel to highly endemic country. And then the prophylactic we use is doxycycline 200 milligram once a week. Okay, that's all from me. Is there any question?
Then, any questions not? Everybody otak tepu already. The one suggesting the yes, no. No say no lah. No questions lah. No
Doctor,
questions lah. Okay lah. Yeah.
I want to ask, when I make some comparison lah, in adult and child punya dengue, dia punya kalau kita nak research tu, in child dia lagi banyak dia punya fluid. Sebab apa? Compared to adult.
Oh, sorry. What do you mean? You mean in pigs they use 20 mils per kilo and in dogs they run fast one time, is it? Is that what you mean?
Dia punya kalau macam fluid research kat dalam chart dia lebih banyak dia punya.
We give 20 mils per kilo and or sometimes 10 mils per kilo depending on the situation, kan? Adults just run fast one time. We base it on the requirements of the child in as volume expanders. If the deficiency, we know through studies that the deficiency that you need during resuscitation for things like if it's hypovolemic shock, we know it's a 20 mils per kilo thing. For adults, actually I don't know why I got nothing to do. But in pigs, it's because it's the requirement, like what we learn. And anyway, after 20 mils per kilo, that is for kids who are actually in shock. Then after that, you assess if it's better than 10 mils per kilo, 10 mils per kilo, because you don't want to overload them. For adults, I'm not sure why only one time. They say run one time, then. True, no? Either that or give volume expanders. You should ask your adult physician. I'm not sure why in adults you need one time.
Okay. So for yang 20 ml tu memang requirement untuk ni lah kalau hypovolemic ni lah.
Yeah, in hypovolemic shock within a active resuscitation, that is what studies have shown. 20 ml per kilo, we assess 10 ml per kilo, 10 ml per kilo.
Okay. Okay, thank you, Doctor.
Doctor,
Okay.
I have a question. In Wave syndrome, the biphasic course is distinguishable. So We can say that is monophasic or is still biphasic.
But it's mean as biphasic, right? If it's biphasic, it's biphasic lah. Can you pull up your that slide? The slide is that. It's biphasic, isn't it? Guys, yes or not? If they've already labeled it as biphasic, why are you going to label it as monophasic? It's still biphasic, right? Right? Any other questions? No. Oh yeah, I forgotten my basic physiology. Back to the fluid resuscitation thingy. Children's fluid requirements higher or adult fluid requirements higher? You guys remember not your physiology? Do you remember whether your adults have a higher fluid requirement or do children have a higher fluid requirement?
So, child.
Huh? Child kan?
Mm-mm.
What? The basis is from there probably. Why? Because because you got children got higher body surface, right? So loss is also higher, isn't it? Children's metabolic rate is also higher, isn't it? Right? Yeah, so that's probably why the fluid requirement in children is higher, and why during resuscitation they use a higher volume.
Okay, thank you.
Any other questions? No? Oh, you're not back at the campus, kan? Oh, you're not back yet, right?
Next week, Doctor.
5 years are there already, right?
5th year already there.
Oh. Why you can't? Okay. If don't have, then okay lah. Bye-bye. Today no time for extra videos.
Yeah, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Doctor.